All right, chapter 21 is your review chapter from A&P. I always did say that those tables were very important because they hold so much information in them. So I would definitely pay attention to those. You're probably going to see things like your cranial nerves again. You're going to want to talk about the types and functions of those. If you're looking at table 21.3, those are your neurotransmitters. The neurotransmitters are always important. I don't know exactly how in-depth this is going to be, anything about anything, but if I was looking at it, this would be the things that I would think was important. In your review chapters, the first few pages always have a lot of bullet points, and those bullet points kind of take the chapter and break it down for you, and they were always important because that was the biggest hunk of review from your A&P. So definitely pay attention to those bullet points on the first few pages. Table 21.4 is not something I would think that would be highly important. Again, I don't know what he's stressed on, but I would look at box 21.1 because that's got kind of it says a classification of common neurologic disorders, which you probably get onto in the next chapters, which probably are much more interesting than this one. The health promotion bullet points or boxes are always huge because preventative care is huge in America. Well, it's huge everywhere. So, I mean, we really want to focus on preventative care. That's a huge goal of Healthy People 2020, which I now think 2030 is coming out soon. So pay attention to anything in here that says preventative care or health promotion. You've got a clinical cue on 479. It's the mnemonic for remembering the central nervous system names. I would probably look at it. The cranial nerve names. I'd probably look at it if you have trouble remembering those cranial nerves. That would be something I normally would have put on this test, was a review of the cranial nerves. I'll get you some more in a minute. To go over there and get you a Kool-Aid for now, and then I'll get you some more milk in a minute. Put that in the sink. All right.
Leave it on the counter.
Now, diagnostic testing is always huge in this chapter. Remember, if you see anything that says a radiograph, it's probably just an x-ray, so take it as you hear it. So if I see skull and spine radiograph, I'm probably just getting an x-ray of the skull and the spine. A lumbar puncture, or what you see as a spinal tap, is huge in these chapters. We use a lumbar puncture to test for lots and lots of neurological disorders. So I'd really try to pay attention to that one, look at positioning for it. Look at some things that can happen if the lumbar, I won't even say if the lumbar puncture is bad, just some types of things that happens after a lumbar puncture, such as a spinal headache, because we know that, we're going in between those spinal processes and trying to get into the spinal fluid, and sometimes that little hole doesn't shut and you leak spinal fluid and your brain loses cushion and your meninges lose cushion, and that's not really, kind of hurts. So pay attention to that. An EEG is also a big one when it comes to neuro because that's usually how we're checking for things like epilepsy. In an EEG, we're really trying to cause you to have a seizure. EEG is, pretty much just that. Sometimes they'll do it when you're awake. A big thing about an EEG is I usually don't want to do an EEG if you've had something to sedate you. I usually don't want to do an EEG if you've had something to sedate you because I want your brain to be functioning at its original speed. So when I introduce these light sensations or sounds or whatever it is, then your brain will become reactive to it, and I can see if it's going to cause seizure activity. A lot of why people with epilepsy can't go around bright flashing lights. If you want to see that, there was hey son, what was that video where Kanye West had that video? All the Lights, was that the name of that song? In that video that had all the flashing lights and you couldn't watch it if you were epileptic? No, I think that's it. You should watch it, not if you're epileptic though. But watch that video, and that's kind of like what an EEG does. A MEG testing, you don't see a whole lot, but remember, if you can remember that it says magnetoencephalography. I'm really horrible with pronouncing anything. If you can remember that it says magnetoencephalography, oh man, you guys remember how much I cannot say anything. Then you'll be able to pinpoint it down, but that's not one that you use a whole lot. Myelography is to detect spinal lesions. I would probably pay attention to that one because we use that quite a bit. Let's see here. CAT scan or CT scans are always going to be huge on anything, all right? So make sure that you're looking on, definitely for things that you can watch your patients for, that you cannot, reword that, things that you cannot do with a CAT scan, all right? And things you cannot do with an MRI. Like metal plates, you can't have metal on, you can't have jewelry and all that stuff for an MRI because it's a magnet. And there's CAT scans, some things that you cannot have, certain medications. Always know those because you'll see those things on a test and they'll be sneaky. Okay, so in here it says requires a consent. May be done with or without contrast dye. That's a big one because there's lots of people who are allergic to contrast dye, so remember that one. Let's see here. Even for a CAT scan, it says to remove hairpins and jewelry. But anytime I'm having any kind of procedure like that, or if I'm going to surgery, anything it's always a good idea, to watch the jewelry. Okay. All right. Let's see here. Going on down, a brain scan. You might see that one again, so I would pay attention to that one. That's just so I can pretty much look at your brain. I mean, there's all kinds of ways that I can look at your brain to see if you've got a lesion or a mass. Remember, a CAT scan and an MRI is really cool because it's not like an x-ray. I can kind of it's almost like cutting the brain in half without actually having to cut the brain in half. And a brain scan sort of does the same thing. But I would pay attention to that one. Make sure you're looking at that MRI. Let's see here. Sometimes you might see an MRA, not a whole lot, but I would pay attention to that one. A PET scan is a big one to pay attention to. PET scans used to be quite popular. I don't know if you probably still see those quite a bit. But a PET scan, usually when you hear of a PET scan, you're usually looking for cancer. But I would definitely pay attention to that PET scan. Let's see here. Carotid duplex Doppler studies. Just when you get to a test that you don't know, break the words down. Okay? If it says carotid Doppler, then you know it's got to be with the carotid and you know what a Doppler is. So they're pretty much getting an ultrasound or carotid. So anytime you get stuck on a test, what the test itself does, just start breaking it down. Look at those answers. See if any of them fits with exactly how you're performing the test. There's lots of tests in here. It's crazy to try to remember them all. All right, neuro's huge. So you really need to try to figure out how to break them down. And some of these tests you won't see as much as the other ones. You really don't see that one. All right, a big one, cerebrospinal fluid analysis and culture. Remember, there is absolutely no way that I can tell if anything's wrong with you, bacterial-wise, unless I culture whatever the fluid is, whether it be a wound, cerebrospinal fluid, blood, whatever it is. I have got to culture it to see if it's actually got bacteria, all right, and to see which bacteria that certain antibiotics are susceptible to, all right? So if I'm doing a lumbar puncture, yes, I'm going to look at it to make sure it's clear. If you've ever seen a spinal tap or a lumbar puncture, they hold up the fluid and you can see if it's clear, then you're usually saying, oh, it's probably not meningitis, there's probably not bacteria in it, but they still need to send it down for a culture. All right, I can't rely on my eyes on its own. And when I get that culture, then I'll be able to see some of the antibiotics that it's susceptible to. So I won't put you on an antibiotic that won't work. All right, so, and a plaque, lipoprotein-associated phospholipase. It's just an enzyme marker. I don't know that you'll see that a whole lot. And if you do, it's probably not anything that you'll ever realize. You'll probably be working, I don't know. I don't know that I've actually ever seen it on the floor, so I don't know that I pay too much attention to that one. All right, make sure you know your reflexes. On the bottom of 483, there's talking about Babinski. Understand why you need to know a Babinski reflex. The book says reflexes are graded as follows. Remember that one, okay? Clonus is a continued rhythmic contraction of the muscle while there is continuous application of stimuli. You don't really want a clonus, okay? Remember, that's kind of what you don't want. Another reflex action widely used as diagnostic aid in CNS disorders is a Babinski, in which elicited by scraping an object such as a key along the sole of the foot. In a normal response to this stimuli, the toes will bend downward. It's opposite in a baby, but right now it will bend downward, and a positive Babinski would go backwards. All right, so that's not something we want to see. You might see a Babinski. Actually, I see a Babinski quite a bit working on med-surg or anybody that's got neuro checks. So pay attention to that one. Always look at your assignment considerations, because a huge part of the NCLEX is going to be delegation. Delegation. Your focused assessment is always huge, and that's going to be on page 485. That focused neuro assessment, you'll use that for the rest of your career. If you're working in med-surg, if you're working with geriatrics, you're going to use that focused neuro assessment all the time. So let's take a look at a little bit of those. It says, do you or does any member of your family have any genetic disorders of the nervous system? I'm going to ask that question regardless, maybe not nervous system, but if I'm doing a cardiac focus assessment, I'm going to ask the same thing about cardiac problems in the history. And it's usually mothers, fathers, grandparents, sisters, brothers. Okay? Just depends on which focus assessment I'm doing. Have you ever had a seizure or told you have epilepsy? Have you had difficulty speaking, concentrating, remembering? I'm looking for neuro problems there. Have you ever injured your head? That's a huge one to ask. A lot of times you might say somebody gets up in a couple of weeks, they're fine. A couple of weeks later, they're talking strange, but sometimes we forget to ask, did you bump your head anywhere? I've actually had a patient who hit her head. Actually, I've had quite a few people who have hit their head and passed away. But we had warning signs before. But in their situation, they were too old. They were on blood thinners, things that we just couldn't bring them back from. But sometimes it's as easy as asking, hey, have you fallen recently? All right. Sometimes we want to jump to Alzheimer's, dementia, when in fact that it's maybe they took a tumble and they knocked their head just a little bit. And, we might have to do some brain scans or something to see. Let's see here. A fever. A fever is a huge one. And I know you guys were around when Christian had his seizure and they were talking about fevers. So just remember that having a seizure from a high fever when you're an adult is kind of weird. All right, you're usually going to see that in children. But that doesn't mean that a high fever cannot cause brain damage. Depends on how high it gets. Any severe sinus, ear, or tooth, or any kind of infections like that, that causes a lot of problems when it comes to fluid buildup. But really, if you let a sinus infection, I suppose, go too long, it can cause problems. All right. The rest of it's pretty self-explanatory. Have you blacked out? Have you had any kind of tremors or anything like that? Read through that. It's hugely important. It talks about your vital signs. There's never a time vital signs are not going to be important. But remember, you're going to have those questions that say, what are the most important? So, you might have questions that say you've walked in and somebody is confused. All right? And there's a list of things that you need to check first. And then again, you need to start looking at your ABCs. All right? And sometimes we try to get away from that, but if I've got somebody that's confused just out of the blue, and I walk into a room and it's going to give me a list of things to do to see what's going on first, that first thing that I do might be check their oxygen saturation, because that's one of the first things that I can help, okay? Because that's airway and breathing. So it could be that something is stuck or their oxygen is just low. Maybe not necessarily check their vital signs first, but check their oxygen saturation. Just keep those things in mind. Let's see here. All right, on the bottom of that same page on 485 talks about level of consciousness. That's going to be a huge one, and I'm sure somewhere in here is Glasgow Coma Scale, and that's going to be a big one too. Yes, on the next page. Your Glasgow Coma Scale is going to be a big one, so pay attention to that. You've got your pupil gauging on the top of the next page too. Just remember, if I don't have reactivity, remember your PERLA. I want pupils equal reactive to light and accommodation. They should be, unless there's been some kind of previous brain injury in the past. Some people are born with pupils of different size, but, you know, you can ask them that. But I should have pupils that are the same size and that react equally when I shine my light into them. Oh, and remember on level of consciousness, Glasgow Coma Scale, that your higher the number is, the better one. All right, so remember that. Let's see here. All right, your next page has decerebrate and decorticate posturing, hugely important. Make sure you're paying attention to that. The next page is pupillary abnormalities and possible causes. I would look at that. Let's see here. You got an assignment consideration on that page too. All those are going to be important forever and ever and ever. Assignment considerations. Okay, the next page has got your lumbar puncture and how they do it, which remember I said go back and know how you need to position your patients for your lumbar puncture. You are going to be the one in charge of getting all the material together, usually for the lumbar puncture. You usually bring everything in for the doctor. You get the patient situated the way they're supposed to be, and you're there for comfort for the patient. So really pay attention to that one. That one's a huge job for you. Now, the next few pages, it looks like, are nursing diagnoses. Now, you be careful on that one because, remember, technically speaking, you are only a part of making that diagnosis. The registered nurse makes that diagnosis. So I don't know that I would get too far into that when I don't know how much it's stress for you guys to know those nursing diagnoses. But if you'll just stop and think about this problem, if it's neuro, you make sure that they're safe. All right? Remember, their NCLEX is a huge safety test. You've got to make sure these people are safe. If they're epileptic and they're having seizures, are they somewhere close to the ground? Do they have padded bed rails? Things to keep them safe. If they're confused, you make sure. That's a huge safety issue as well. So, and if I've got people who are comatose, then I'm looking at skin. All you got to do is just stop and think. What are the problems that I'm looking at right now? If I was that person laying in the bed, what might happen to my body? And if you can think about those things, then you'll be able to derive a nursing diagnosis. I know I'm worried about skin. If I lay down for a long time, what's going to happen to my lungs, right? If I lay down for a long time, what's going to happen to my vital signs? If my vital signs get screwed up, what's going to happen to my blood flow, okay? Just take that ladder down, all right? Every nursing diagnosis that you see, you're going to have something offshoot from it. Let's see here. And going on through the rest of this chapter, it looks like they're breaking down each individualized the nursing diagnosis, ineffective breathing pattern. You know, if I'm laying down for a long time, I'm not going to breathe good. What happens if I don't breathe good? I might end up with pneumonia or atelectasis. If I'm laying in bed for a long time, remember we always said, if you don't use it, you lose it. So if I'm laying in bed for a long time, my muscles are going to atrophy and I won't be able to walk. You know what? Remember what helps me breathe? When I'm up walking, and skeletal muscles, okay, and my chest muscles. All those things go downhill. So, you know, if I'm stuck in bed because I've had a stroke, you know, I can't walk, I'm comatose, I'm really worried about your respiratory status. Self-care deficit, that's going to be your stroke. Probably your Parkinson's, people who cannot take care of themselves. If they can't take care of themselves, their health is going to decline. Dysphagia, you remember dysphagia? I'm really worried about swallowing theirs, so I have to watch people so they don't get choked and aspirate and get pneumonia. Incontinence is something that happens to a lot of people with neuro problems, but if you're incontinent, you're just laying in your own waste. You know, it doesn't matter how fast I get to you and clean you up. A lot of times it happens just like that, so I have to be vigilant about that. Bladder training, remember back from before bladder training, it would be something I would have a Foley catheter in, and I would lock that, or I would put a rubber band around that tubing, you know, a few times a day, and let it loose a few times a day, just like I would a normal bladder schedule. So my bladder starts to remember, hey, I can't just empty all the time. Bowel training's the same way, except for typically bowel training is much harder because there's not a Foley you could put in there. They do have those those bowel, I can't remember what they're called now, but they're very uncomfortable tubes that you put in your rectum. I don't think I would want one in there, but they do have them, but I typically don't ever use those. Pain's going to be huge, because even for people who've had a stroke, because a lot of times, even though they might not be able to feel where it's affected, if I start to draw up, then I'm going to maybe have pain somewhere else that wasn't affected. So watch that one. Confusion's also going to be a huge one, because confusion equals not safe. So on those people, I'm really looking at the safety on everything. You've got a focused assessment for aphasia problems. Pay attention to that one, because you're going to have lots and lots of patients with aphasia. You're going to see that on the test, at least on the NCLEX. I don't know about this test. But really pay attention to what you can do for your aphasic patients. How do I position them to eat is a hugely important thing. When I'm talking to them, remember, they're not going to be able to converse with me like they used to, and that's very hard for them. I need to give them ample time to talk to me. Sometimes I need to figure out another way they can communicate. And just remember how hard it would be not to be able to communicate and tell people what you're trying to feel. Very agitating. It goes on to talk about sexual dysfunctioning too. We don't think about that one a lot, but that's huge for a lot of people, because, well, that's just huge for a lot of people. All right, so that's 21.